Welcome everyone to the Clusterbusters webinar on neuromodulation. Thank you so much for joining us. We're glad you're here. A lot of people have come to Clusterbusters asking about whether neuromodulation is a good option or whether it's like a real treatment for cluster headache. Since it's not something that's discussed broadly, some people just don't know enough about it to make an informed decision. So we wanted to take a little time to learn about the science of neuromodulation and what's available right now, and maybe a little bit about what's coming in the future in this area. With us this evening is Dr. Emmanuelle Schindler and Ms. Anna Williams to help you through learning about neuromodulation. I'm going to tell you a little bit more about them in a minute, but first I'd like to do a little bit of housekeeping. During this presentation, at the bottom of your screen, there is a chat option. Please feel free to chat to everyone who is attending, or you can just send a chat to the host and panelists. You can also access the Q&A. You can ask questions during the presentation. We'll have a Q&A at the end of the presentation, so you can put your questions there and we will address them at the end. You can also put your questions in the chat and I'll pick them up there as well. So either way is fine, whatever makes you the most comfortable. If you're having any difficulty during the webinar, you can email me at Eileen@clusterbusters.org. Let me start by introducing our panelists. If you don't know, Dr. Schindler is the medical director of at the Headache Center of Excellence at Veterans Affairs, Connecticut Healthcare System, and she's an assistant professor of neurology at Yale School of Medicine. She's a board certified neurologist and a headache medicine specialist. She has developed and executed the first controlled trials of the effects of psilocybin in cluster migraine and post-traumatic headache. She has been a speaker at the Clusterbusters conference for many years and helped us to navigate the world of cluster headache treatment in so many ways. I can't even tell you. She is amazing, and I just thank her for being here. Anna Williams lives in Indiana with her 2 teenage daughters and 5 fur babies. Her cluster headaches began in 2012 and she turned chronic in 2017. She has been an amazing advocate for the entire headache community. She's been to Headache on the Hill. She has provided cluster info through writing on migraine.com, and she is admitting a new Facebook group called Medical Marvels. She focuses on supporting and encouraging, and she's really funny too, and I love working with her. So thank you both for being here, and now I'm going to turn it over to Emmanuelle Schindler so that she can tell us all about the science and clinical practice of neuromodulation.
Thanks, Eileen, and thank you for helping to put this together and for inviting me. I'm a big believer in neuromodulation, and I think it should be used more, but there's a lot of lack of information or misinformation out there. So I'm happy to talk about it and share my experiences. I'm going to start my presentation. Let's see, okay. So my disclosures are here. I have previously received research funding from Clusterbusters, and I'm also on medical advisory board as well. I hope to give a little bit of background about neuromodulation and then talk about two devices that are that sort of target cluster headache, and I'll mention some other devices that are not really for cluster headache, but you may hear about them, and you may hear your doctors trying to prescribe them for you, but I'll go over those briefly, and then we'll have a Q&A at the end. So first off, neuromodulation. First, backing up a little bit from there, to understand neuromodulation, you have to understand a little bit about what headache is. And headache is not just pain on the head or in the eyes. It's a brain disorder. And there have been several brain regions mapped out during headache attacks, both cluster and also migraine, and other headache types that have been mapped out throughout the brain. And this includes parts inside the brain and parts outside of the brain too. We typically think about headache treatment in terms of pharmacological treatment, treating all these different brain areas from the actual neurotransmission. Some of these drugs target the sodium channels along the axon that will impede neurotransmission. And I list some examples of some medications that might be tried in cluster more often in some other headache types, but that you may have been prescribed. The actual release of neurotransmitters at the axon terminal requires a functioning calcium channel, and so verapamils are probably most well known. Cluster headache preventive that targets that channel. Botox is in charge or targets the system that's in charge of packaging neurotransmitters and releasing them. One of the neurotransmitters, serotonin, is very important for headache disorders, and so we have drugs that also target that system, the triptans and the tricyclics, and also psychedelics that target the serotonin system. And then some of the newer drugs target CGRP, which is one of the inflammatory molecules that gets revved up during a headache attack, and that is revved up in headache disorders. So there's multiple levels that medications target, and they work for some people, not for others. And so how else can we target headache disorders? And that's where neuromodulation comes in. And this is not a newfangled concept. This is a concept that's thousands of years old. And believe it or not, people used to actually harness the power of the torpedo fish to cause neurostimulation on their limbs to help treat various pain conditions. Thankfully, we've moved beyond using the torpedo fish, but the concept is the same. And this is largely targeting nerves on the outside that then feed back into the systems in the brain and the spinal cord in some cases to help modulate pain. Some of these neuromodulation devices, they're actually implanted. This is some examples, not only for headache disorders, but deep brain stimulation is used for conditions such as Parkinson's. It can be used for cluster headache as well, targeting the posterior hypothalamus. This is obviously very invasive and has a lot of risk. Occipital nerve stimulation is used in cluster headache and other headache types. But it's not always effective, and there's also a lot of potential side effects. As you can see here, there are components that have to be implanted. The vagus nerve has been the target for not only pain management, but also epilepsy for many years now. Here's just an example of an implanted vagus nerve stimulator that wraps around the vagus nerve and then has a stimulator and has wires and a stimulator on the outside. So thankfully for headache management, we have external devices and less invasive ones. And so the first one I'll talk about is the non-invasive vagus nerve stimulator. And so here is a picture. The older one looked like this, and now the newer one looks like this. And it targets the vagus nerve, which is also known as cranial nerve 10. And it has a lot of different functions. It does modulate a lot of the other nerves, the ones responsible for the pain sensation that's part of headache disorders. There has been more research in this area, specifically because it's been so successful in headache disorders. And I won't go through this whole thing, but this was a study where they looked at different brain areas, whether they were activated or turned down, and the connection between brain areas. And vagus nerve stimulation does cause changes inside the brain. So it's not just working on the outside, not just helping to treat pain on the surface, but it's actually having measurable changes inside the brain. There are a number of studies that were done, first off for acute treatment. So just for treating one single attack at a time, we have the ACT studies. Here's just one of the graphs from one of the studies. And when you look at it, they broke down all cluster headache patients, episodics, and then chronics. And the treatment of an individual cluster attack did not look like it didn't look like it was different from the sham device, the device that wasn't actually transmitting enough of a signal to cause stimulation. But when breaking it down between episodics and chronics, there was about half of the episodics did have relief, whereas only 6.2% of those who had the sham did. And so this is where the effect was seen, was in episodic patients, not in chronics, and that's why the vagus nerve stimulator was cleared for episodic cluster headache. But honestly, it does work in both. I think this is just a factor of a controlled study. Is not going to show you real world efficacy all the time. So there's also an effect in the prevention of cluster headache, and this is an open label study with I meant to say 19 patients, not 15 patients. They looked at both the acute and the preventive effects, but here's a table of all the patients, and for the couple months of the study, how many attacks per day they were having before and then after. And you see that the majority of patients had a reduction in the number of attacks. The last 4 didn't really have much change. So again, this speaks to the fact that this may work for some, but not others. But the average reduction was 4.5 attacks per day, down to 2.6 attacks per day, and that was very significant. This device is also approved for migraine headache as well. There are 2 different. There's actually 4 different when you count the acute and the preventive treatments. It's very important that with this device that you do use the right treatment that is for your condition. The migraine acute regimen wouldn't work in cluster, for example. And so this is in the insert for the device, but it's always good to go over it with your physician. There are, and we'll probably have some more time towards the end. And also Anna's going to show you her device, but I have the GammaCord device here and the components, so I can go into some more detail afterwards. There are some side effects, just like any medication has side effects. Neuromodulatory devices have too. There can be some discomfort at the site where you stimulate on the neck. Some people have some lightheadedness or vertigo, but that's not too common. And it can't be used in people who have other devices implanted or a couple other conditions. And the device was not studied in children or in pregnancy, and so that's why they have that listed there as well. The device itself does require training. You really can't just give it to someone and say, here, start using it. Even just the 4 different regimens for migraine and cluster and acute and the preventive use. I know patients are sometimes prescribed this and just told to kind of figure it out. So it is important to recognize the acute and the preventive treatment regimens. Finding the location on the neck, you have to really kind of, it may take several tries before you really find out exactly the angle, because you're trying to get the vagus nerve, stimulating it, and you know you're in the right spot when you feel your lip twitching or your cheek twitching, and it may take several tries before you actually find it. So people may try it once, it doesn't do anything, and then stop. They really have to try again. The device itself is either a 30 or a 90-day device, and it counts down. Once you start using it, it'll count down every day, whether you use it or not. So don't try it once and then put it aside and then forget about it. Once you start using it, it's already, the timer's already going. And there are numbers on the device that tell you how many days you have left and then how many stimulations per day you have left. There's 30 stimulations per day, which allows people to, with cluster headache, to use it as a preventive and to treat for cluster attacks. So it has a good number of stimulations already built into it. It doesn't roll over like most phone plans, doesn't roll over either. The electrodes, you have to put a gel on it. There's a gel that goes on the electrode portion. Don't use alcohol or water to wipe it off. These are all things that I've heard people do, and it can make the device not work. So all these little things, these things really patients have to be trained on, and I feel like they're not always charging the device. The device comes in a case and it gets charged, it gets plugged in the back and it's charged in the device. So a lot of little things about how it's used. So we could talk more about this device specifically since it is actually approved for cluster headache. But I want to also talk about the spinopalatine ganglion stimulator, which many of you have heard of or have maybe even participated in the studies. Here it is implanted in the cheek, and then there's a remote that actually activates it. The way that this works, so the spinopalatine ganglion shown here, it's also called the pterygopalatine ganglion here. It's in communication with the trigeminal nerve, which is the nerve that is processing pain signals. So this is how it can modulate pain. And it was developed as an acute treatment, but it also might have some preventive effects too. Here is some work from some studies here for the acute treatment of the 6,000 or so attacks that were able to be studied. 65% of them had relief or pain freedom at 15 minutes. The different severity levels of the attacks, mild and moderate, were and severe were still very effective. The very severe attacks, not as effective, only 23% had some relief or some freedom, but not bad, since very severe attacks often don't respond to much of anything. And then in patients who were using this long term over 2 years, their number of attacks per week also went down. So there can be some preventive effect too. Some more research, I won't go through all of this, but both some acute and some preventive effects as well. One of the more common side effects was numbness on the side of the implantation. And people may have different experiences with this, and whether they had permanent or temporary numbness. And many of you already know that this device was being developed by ATI, and then the company was no longer able to continue. It has now been bought by Relieve. I think I had the name in the beginning here, a company called Relieve. So they're actively working on it. And then more studies will be required in order to obtain FDA approval. So this is something that I'll be keeping an eye on because I do think that this is really directly targeting part of the anatomy that is directly connected to the nerves that are important for cluster headache. So some other devices I'm just going to briefly touch on, and you may have heard about these or been prescribed these devices. I have not found very effective, or I haven't even tried in cluster because it's really meant for migraine. Cephaly is probably one of the more common ones. This one has been around for some time. The older version looked like Xena Warrior Princess, and the newer one has an electrode that sticks on, and then the device sticks on there. It targets the terminal branches of the first division of the trigeminal nerve. It can be used both as an acute treatment and a preventive treatment. And it's really, for those of you who may have tried it during a cluster attack, I'd be curious to hear what your experiences are, but I don't prescribe this for my cluster patients. For migraine or for post-traumatic headache or some other headache types, I might give it a try. One of the newer devices is the Neuromodulation device. This is a device that straps onto your arm, and it uses the phenomenon of conditioned pain modulation. And this is kind of neat because I feel like cluster headache patients kind of do this when during an attack, when you pace and when you rub your head or hit your head or induce pain somewhere else on your body, that distracts from the pain from the headache. So this device actually uses that same concept but it's only approved for acute migraine treatment. It's a 45-minute session that will stimulate you're supposed to crank it up to a point where it's bothersome, and that will activate the descending pain modulation areas of the brain to help turn down the pain of your headache. This is interesting. I'd be curious to see if it might have an effect in cluster if you crank it way up. I tried it on myself just to see what it felt like, and I couldn't go past like 15%. So the 100% maybe would be enough of a stimulus to help distract for a cluster attack. I'm not sure, but this is one of the newer devices, and I'm still getting some experience on this. But for some migraine patients, it can be effective. The last device that I'll just touch on is the transcranial magnetic stimulation device. This has been used in mental health as a much larger device. This is a smaller handheld one. And the idea is that it has activity on the thalamus, which is one of the regions of the brain that's involved in headache disorders. And it's improved and it's cleared for migraine for both acute and for preventive therapy. I don't have experience with this in cluster headache patients. I don't know if anybody has been prescribed this device, but just like the Nerivio and the Cephally device, these have not been studied and are not really approved for cluster headache. So at this time, I'll turn over to Anna, and we can talk, answer questions, and then go through some of the device details afterwards as well.
Thank you so much. All right, Anna, you're up.
Hi, everybody, and thank you guys for being here tonight. So I'm going to kind of go through my patient journey and kind of talk about my diagnoses and the different things I've tried and what has worked and what hasn't worked. So I started getting headaches by age 10. I just thought it was a headache, didn't really think a lot about it. It wasn't until my 20s, my mid-20s, when I finally went to a doctor and was diagnosed with episodic migraine with aura. And so I got some treatments and I went on and I started having a lot of sinus pain, and the doctor would just diagnose it as a sinus infection. But at one point in 2009, 2010, the doctor determined I'd had too many sinus infections. And so they sent me to the ENT. And he talked me into sinus surgery. He pointed out different things that he could fix, and he really thought this would get rid of my headaches. So I went through the surgery. And as I was healing up, I realized it hadn't fixed anything really. But what it did do is it helped me understand my pain better. And I still knew there was something else going on, but I didn't know what. So in 2012, I had a new onset headache. I had completely different symptoms. I knew something different was going on. And I had a headache specialist at the time. And so I noticed that every single day at 2 p.m., the headache arrived. It was completely unilateral. My eye and my nose acted up, and the pain was very different from my migraine. And by 3 to 4 p.m., it was gone. And unfortunately, it was the time when I was picking up my kids and when everybody was coming home. So I was trying to cook. And so it was just really stressful. And he convinced me that because I have migraine, this had to be migraine. And he was very frustrated with me because of what I had taken in the past and I couldn't take because I was either allergic to it or had severe adverse reactions. Me and medications haven't gotten along really well over time. And so he finally got frustrated and he was like, here, take this. And it was a calcium channel blocker. It was not verapamil. It was actually amlodipine. And it worked. It was like a magic pill for me. Like the pain was completely gone. I was so excited. And so I thought, well, it's gone. So I ran out of the prescription at one point. and I had trouble getting it refilled. And so I went off of it, and sure enough, they came right back. And I was like, okay, I can never let this prescription lapse. This is my magic pill. So we're going to fast forward to 2017, and this is where things got really messy for me. So in the spring, I had what I thought was dental pain. I went to the dentist. They saw something very superficial. The dentist said it was very superficial, and they fixed it, and the pain did not go away. And so I didn't want to go back to the dentist. It took me a couple months. I'll go back, and they tried something different, still didn't go away. So after a couple more months, I was like thinking the tooth had to be extracted, because that's what the dentist said. He was like, if the pain doesn't go away, then it's just going to have to be extracted. So I go back completely thinking it needed to be extracted. But during the appointment, he made the comment, he said, I just can't pull a healthy tooth. He said, I really think there's something neurological. So given that, I go home, I start researching. And so I was like, okay, I need to go to my headache specialist. So I go, and 2 days later, I got in super fast. 2 days later, I'm diagnosed with trigeminal neuralgia. So by this time, we're getting into fall, and I had no medication I could take for the trigeminal neuralgia. And those headaches, those new onset headaches from 2012 were back, and they were worse than ever. And I had no medication, and I was completely lost. And so I found another doctor, I found another neurologist, and he confirmed I had migraine, cluster headache, and trigeminal neuralgia. And I had kind of started figuring out it was cluster because my grandpa had cluster. And I realized when they came back and they were worse than ever, like as I was pacing the floors, I remembered my grandpa. So that made sense to me. So I was struggling with treatments. And so in 2020, I started getting something very new, and my neurologist was completely lost as to what it was. And because of cluster busters, I'd been exposed to the different attacks, and I realized I was most likely dealing with SUNCT. And so I ended up working with a headache specialist through telehealth, and found out it was indeed SUNCT. So I just kind of want to go through the diagnoses real quick. Migraine, for me, it's always on my right side. It lasts, for the day, or it may last 3 days, 2 weeks. It really varies. The cluster headache is strictly unilateral. Interestingly, they're always on the left. I've had a few cycles go to the right, but typically 90% is on my left. My eye is red and it waters. It literally feels like I have a hornet stuck in my eye socket, and it is just stinging me over and over again. And every time this sting comes, more water comes. My nose is stuffy and runny. My eyelid is swollen and droopy. I don't usually get facial sweating in some severe attacks I have. I'm pacing, I'm rocking, I'm moving. Like Dr. Schindler mentioned, I am doing anything to distract from the pain. And then I would get the shadows, and those make me feel like I'm on edge, like the cluster attack is about to come at any moment, but it's a very low level pain. So with trigeminal neuralgia, more often it's in the second and third branch, and that's where mine is. I get the shocks in my cheek and in my lower teeth and jaw. It's constant throbbing, aching. It's constant when it's unmanaged. And it's easily triggered. So if I'm doing just fine in a house and I walk outside and it's a windy day, the attack happens instantly. hot or cold beverages or food, brushing my teeth, just basic things is really difficult with trigeminal neuralgia. And I ended up, again, because I was unmedicated, it ended up going to my other side as well. And so I became bilateral, but it's one of those things because the nerve isn't connected. You're dealing with 6 different branches of that nerve. And so one branch may act up today and another branch act up tomorrow. So SUNCT is the most rare of the ones that I have. And it's just an acronym that lists symptoms. So it's short-lasting unilateral neuralgia form headache attacks with conjunctival injection and tearing. And what I experienced was sometimes when I would get a cluster attack, I would start getting these other attacks, and they were really short. So if you imagine the hornet, this was like a sweat bee. It was a tinier sting. It wasn't as painful, but my eye would tear and water. My nose was stuff and run. And my eye looked just like cluster. It was swollen and droopy. And with SUNCT, it's different than trigeminal neuralgia for me because it's like cluster. It's like an episodic cluster person who that light switch comes on and they're just getting attacks. But when that light switch goes off, they can be exposed to their trigger. Alcohol is a common trigger. They can drink alcohol and not trigger an attack. So SUNCT was very similar. That so long as the light switch is off, nothing triggered it. But once that light switch came on, everything was triggering and I couldn't get it to stop. And so I would go for 5 to 7 days where every move I made would trigger another attack. And these attacks would last, I couldn't really time them, but I'm guessing 30 to 60 seconds. And then I might go 60 seconds to 20 minutes with no attacks, but then it would happen again. And it was even to the point that since it was my left eye, if I tried to open my right eye to see, just opening my right eye would move my left eye, which would trigger another attack. So I would have to have my eyes closed for 5 to 7 days at a time. So given that this was all that I was dealing with, so before SUNCT happened, in 2018, Aimovig came out and I went on Aimovig. My doctor gave it to me. He's like, it's for migraine, give it a shot. And we were both thrilled when it helped my trigeminal neuralgia. It was the first thing that had ever helped. And my clusters went down probably 40%, which was huge because by this time, I forgot to say this, I had gone chronic. So by the time I had SUNCT in 2020, from 2017 to 2020, I had not gone a day without a cluster attack or more. So I was really excited with Aimovig. I got a little bit better managed, but it was still a lot, to have 15 or more days a month where I would have 1 to 4 attacks a day. And my attacks were lasting 2 hours each. It was absolutely exhausting. And like I said, I've got 2 kids to take care of. So I had learned about cluster busters, and they talk about the D3, which I added very quickly. And then they talk about psychedelics. And I was literally the last person I thought that would ever go that route. But after knowing about psychedelics for a year and still needing more relief so that I could be a mom to my kids, I did dive into psychedelics. And I was really excited because it took me a while. It did. It took a while. But as I found the dose that worked for me and different things, I was down to 1 to 4 attacks a month. as a chronic, I was excited. My problem was I was having sunk. And so I was having sunk cycles about every 6 months. And in January of 2021, I had a sunk cycle, and I had another one in March, and that was 2 months apart. And I was very scared at that point, and I needed something else. And that's when I found out about gammaCore. And so I got a chance to add gammaCore in, and I have been attack free. I have not had a cluster attack since, which has been super exciting for me. It's been over a year now. I have not had a full-blown cluster attack. I still would have shadows, and over time, the shadows are getting better. So for me, gammaCore, so I have this one, and at first I did the one for prevention of 3 stimulations twice a day. And I would find my shadows would get really bad at midday. So I was using it for that as well. And so I just got in the habit of doing it 3 times a day. So that really helped me. And I still was dealing with shadows, but I didn't have the attack. So I was really excited. And I have not had a Sancta cycle since either. More recently, I switched Amavig out for Qulipta to try to help my migraine attacks. And between Qulipta, the psychedelics, and gammaCore, this was my first month without migraine as well. So I'm constantly working to try different things and trying to find what works for me. And I really like that gammaCore is a device because I'm not having to put more medicine because, like I said, I struggle with medication a lot. As far as the other devices, the only other one I've tried is Nerivio, and it does help me manage a really bad migraine attack while the medication kicks in. I did try it for cluster and sunk. I was so desperate in January and March. I was so desperate, and I had my kid help me put the Nerivio device on. And Dr. Schindler mentioned how painful 15% was. And typically I would agree. And I would usually, in a migraine, I would tick it up to like 20. And that would be about all I could handle. With the cluster and the sunk attacks, I had it cranked up over 50. It brought the pain down just a little bit so I could breathe, but that was about it. So it was an interesting thing to try. So that's kind of my story, the things that I've tried. So if Eileen and Dr. Schindler want to come back in, we can do some Q&A.
Thank you so much, both of you, for talking about all of this. We do have several questions. I want to start with, first of all, somebody asked for a clarification, Anna, on your talk about what was the condition called after visiting the dentist? What were you diagnosed with then?
Trigeminal neuralgia.
Okay, and I can put that in the chat. Yeah. If you can't see the chat even to see what we're typing, then the other thing I want to let you all know is that there will be an email following this to everybody who registered to participate, and we'll include some FAQs and information in that email as well. Somebody just texted me and said they can see the chat. So I'm glad you can at least see it. I'm sorry you can't type in it. I don't know why that is. Then there's another question, which I've never even heard of this. So I'm really interested if anybody on stage knows about this. But one of our participants said, when I have a cluster storm, I'm treated at a pain clinic in Belgium. I get a PRF, which is pulsed radio frequency stimulation at C2 and C3. I assume that you're talking about in between your vertebrae. Mm-hmm. is this something that happens in the US? He's chronic and preventive medicines don't work.
Yeah, I do have a number of patients who have chronic neck pain who get radiofrequency ablation at the high cervical level. I've only recommended it for my headache patients who also have significant neck pain. But given that the upper cervical nerves turn into the occipital nerve, if targeting the occipital nerve either with a nerve block, which does often help in patients who have cluster, then theoretically targeting the upper cervical nerves just closer to where they come out of the spinal cord should work too. So it is so yes, that is available, but probably not tried as much as it should be.
That's really interesting. And can you talk a little bit about the difference in between neuromodulation and like nerve blocks?
Yeah, well, there's different levels of the nerve blocks, like the surface ones where we inject lidocaine or something similar under the skin, kind of around the nerve. That sort of temporarily shuts off the nerve function. Like I showed in that picture, it targets sodium channels and other channels to stop the nerve transmission. Then there are deeper levels of stunning the nerve or even injuring the nerve permanently that are done by pain specialists, where you have to have an MRI first, and then they go in much deeper to actually injure or to stun the nerve for a longer lasting effect.
Yeah, I've read about some surgeons that advertise that kind of treatment for cluster headache and other headache diseases, but I've never heard anybody have any success with that kind of surgery where you destroy the nerves. I don't know if it is successful, but I've never heard of it.
I have most experience with the upper cervical nerves, like was mentioned in the question. I have heard of people who will directly also target branches of the trigeminal nerve, and even to the point of actually cutting those nerves. And there is risk with that, because when you injure a nerve, it may try to grow back, and then it may just cause more pain when it grows back. So anything you can do to try to spare actually cutting or burning a nerve or should be tried, because once you cut it, when it tries to grow back, it can be trouble.
That makes sense. Okay, another question. Dr. Schindler, what is your view on other physicians in the VA, like primary care or internal medicine, prescribing gammaCore? Do you think that that's a great idea? I have to wonder about their level of training with the device themselves. What do you think?
Yeah, so a couple of points. I'm spoiled at the VA because that's where I practice, and I can prescribe. There are certain things where you have to try something first and then you can prescribe it, but there's no cost to the patient, so it's very nice. gammaCore is an example of that. But we do, at my VA, we do restrict all the devices to headache specialists. We do let some of the neurologists prescribe some of the devices, those who just happen to see a lot of headache patients. But because there's so much training, and that slide where I just showed some of the details, even the detail about not getting the electrodes wet with anything, that's something that that's just one example. Also things like while the instructions say 3 stims twice a day as the preventive, just like Anna pointed out, she found that doing it 3 times a day was more effective. So, tweaking the regimen for people who do have attacks on both sides, figuring out how to alternate, okay, Monday, Wednesday, Friday, you do the right, and then, or you might alternate in different ways. So that level, all those nuances, I think it does require someone who's going to be prescribing it often enough that they get experience with it, and that they have a system in place to help tweak things. So I know that it does happen, but I do think it's probably because training is so important. I think ideally it would be someone who has more experience in that area.
Thank you. And on the note of that tweaking, Anna, this question, I think I'm going to direct at you. With the gammaCore device, somebody asked if they should use it while they're getting shadows or just when they're actually having cluster attacks. Have you thought about this experience?
I have. I do use it for shadows. Like I said, I haven't had a full-blown, I haven't tried it acutely on an attack because I haven't had one. And when I would get shadows, usually oxygen wouldn't help the shadow. And I was still trying to get good access to oxygen. So yeah, I absolutely did use gammaCore for the shadows because I had easy access to it at that point.
Dr. Schindler, what's been your patient's experience broadly with shadows and using the device, or do you not know?
Yeah, I don't think I have a specific example, but I would say, sorry, I was sick last week, so I'm still coughing. I don't have a specific example, but yeah, I think that trying it during a shadow to see if it'll keep it from turning into an attack should be tried. Yeah.
Okay, thank you. Okay, another question. How long does it take for gammaCore's preventive effects to kick in? Is it relatively immediate, or does it take a few weeks or months of consistent use to start? And I'll start with you on that one. How did it go for you?
For me, once I got it, I didn't get full-blown attacks. My shadows were still pretty bad though, and I was having to watch a lot of things, but I did find it's worked better over time. And so while it did have some effect initially, I think probably 1 to 2 months in, I started being able to breathe a whole lot easier. And then, even now I'm starting to slowly be able to breathe easier. So it's definitely helped by using it consistently over time.
Yeah, I agree. I feel like for just like any other treatment, it takes a little time to get into your system and really start to take effect. Dr. Schindler?
Yeah, I would agree. I would say that as compared to some medications, it may start to kick in faster, but you do have to keep with it to really know what the maximum effect is going to be.
And I feel like this question has been answered, but I'll put it out there anyway. Can I take other medications while using gammaCore? Obviously, with Anna's experience, she's using a lot of different treatments. Do you have anything to add to that?
I think it's important to do more. It depends on your situation, of course, but in my case, the stacking of preventives has helped tremendously. A single one by itself wasn't working. And I was seeking that elusive zero. And I'm still chasing it, right? So I'm still doing tweaks and still doing whatever I can to prevent. And so for me, it was actually really helpful to do 3 very different things to get things to work together.
Yeah, I would agree with that. Coming at the headache through different mechanisms, like I showed on the medication slide, there are different places where you can target neurotransmission. So coming at it by different means can have a greater effect. So yeah, I think it's more often than not that patients may end up on multiple types of treatments.
Thank you. I'm trying to make sure that I've answered all questions. Oh, I actually have a question. Because it's about this device, because you said you both have them, and is there a battery for it? Does it need to be recharged, or how? Can you tell me just a little bit about how it actually like works? Because I don't know.
Yeah, so it comes in a case, and the case has and it comes with a charger. So you actually plug the charger in, and it charges while it's in the case. And then there's a single button when you turn it on. This actually, I hope, yeah, this, I did charge it before. You probably can't see because of the camera, but it goes back and forth between two numbers: how many days you have left on it, and how many stimulations in the 24-hour period. So you always know how much you have. I'm not going to actually start it, because if I do, then this device counts down, and then I'll lose it. But there's a button on the side here where you can crank the intensity up or down, and it goes up to 40, I think, and most people have to hit up to 15 or 20 before it's strong enough to actually stimulate the vagus nerve. And it comes with like 6 tubes of gel, and you put little dollops on the electrodes here, and you feel where your carotid is, because that's roughly where the vagus nerve goes by. And you hold it up, and you have to sort of play around with it until you find the location. Your lip will start to twitch. Anna, what sensation do you get when you know that you're in the right spot?
Yeah, so it starts, the corner of my lip starts drawing down, and it just feels tingly for me.
Does it hurt?
It doesn't hurt.
It just
Like,
feels
it
weird.
feels weird. Yeah.
And so, but I can take this device, like I don't have to keep it in the case all the time. Like if I'm headed to work, I can take it with me in a thing of gel, and
Yep.
you know, it doesn't need to be charged in between every use.
Correct. The charge will typically last two full days for me, and typically a little bit longer. But yeah, I take it with me.
Cool. That's amazing.
And I will say one tip on cleaning, because my first thing was, oh, just wipe the gel off with a washcloth. No, it's really gross. So I just use a tissue or a paper towel and wipe it off. That way I don't have to worry about it, because it's sticky and stuff. So that was my big learning thing.
Sounds like a mess, but worth it if it works.
Oh yeah.
How do you alternate? Do you alternate sides, because you do have problems on both sides?
So it's interesting, because I can hit my left side really quickly, and my right side takes a little bit more work. But because of the cluster, I was using it on my left side. But like I said, I've started getting to where my cluster is calming down. And so with my migraine, I was trying to get it to work better. So since migraine's on my right, so what I'm doing now is mornings on my left, mid-afternoon is on my right, and then at nighttime is on my left.
That makes sense.
And so I'm trying to hit the migraine a little bit more now.
Yeah, it seems like you just figure out what works for you and go with that, and it probably takes time.
Yeah.
Okay, well, we are just about out of time. A couple of closing announcements. First of all, thank you, Anna Williams and Dr. Schindler, for joining us. I really appreciate all of your knowledge and information. If you want to check out this device and learn how it's best used, you can come to the Cluster Busters Conference, September 15th through 18th, and you can meet both of these ladies and try the device out. We'll have a couple there, and Dr. Schindler can help you through the process. Or you can work with GammaCore themselves, with ElectroCore, the company that produces the device. They have one-on-one training support. So if you already have a device and you're like, this isn't working for me, but you never got trained on how to use it, you may want to just check that out, because they can help you through it. We'll be giving you more information in our follow-up email. So definitely check that out. And I just want to thank everybody for joining us this evening. I hope you all have a good night.